And thank you for joining this great session. So let me briefly introduce Dr. Hamza Habib. He's an associate professor of medicine, and he has unique qualifications. Maybe that's a discussion for another day. He's a physician as well as a lawyer, and he is currently the director of outpatient palliative care medicine and cancer pain management at the Rutgers Cancer Institute. With that brief introduction, I will invite our speaker. And this is a topic which is very valid, not only in the USA and as well as in outside the USA, but particularly in Pakistan, India, Bangladesh, a lot of countries where unfortunately the cancer is diagnosed at a later stage, where patients are suffering a lot. So, Dr. Habib.
So much, Dr. Anwar. It's a pleasure to be here, and you're so right. Our focus oftentimes is on the treatment of cancer. We often kind of oversee the fact that there are other things that are far more more debility causing and more difficult for patients to cope with than is pain that is almost universal in all cancer. So I have a quick slide set that I can present, share. Okay. Just wanted to make sure everyone can see the slide set. Okay, so that's me. Thank you so much for the kind introduction. No active disclosures that are related to any that are discussed in this presentation. So the goals for this meeting are, number one, participants should be able to know the types of pain and the pain pathways that are involved in pain transmission at the end of this presentation. They should also be, at the end of this presentation, be able to describe basic opioid pharmacology and the role of opioids in cancer pain management. Number three, they should be able to describe two interventional pain procedures for cancer pain management and their indications. So, starting off with pain, let's start with the basic, right? How does ISP, the International Association of Pain, define pain? So, what they say is that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described such damage. So, there are two parts to this. It has to be an unpleasant sense. There is often an emotional component to it as well, and we see that very often in cancer pain. And there has to be actual potential tissue damage. So those are the two things that basically are important when you define pain. The concept that we use in cancer pain or palliative is the concept of total pain. Pain is just not sensory. Like this talks about it. There is an emotional experience, there's an existential component, there is a spiritual component, there is a social component, psychological component. All these things, they add up, and that's what leads to the distress that the patient has. So that is the concept of total pain, and that's how we kind of focus on pain management when we're talking about cancer pain or pain management in cancer patients under palliative care. So this is something that probably all of us have seen in anatomy classes, biology classes, back in medical college. So let's say one day I'm walking, right? All of a sudden, I step on a nail, something on the ground that is sharp. All of a sudden, what happens is the free nerve endings, type C fibers in my foot, they will automatically perceive that sensation of pain, and they will transmit it up from the peripheral nerve to the dorsal root ganglion where the pain is modulated, and then it goes to the brain, into the hypothalamus, decussating there into the thalamus, and eventually in the cerebral cortex. The idea behind this diagram is that pain can be managed at multiple levels. We can manage it at the level of the foot, we can manage it at the level of the nerve, we can manage the level of spinal cord, we can manage it at the level of brain. So these are different opportunities that we get to have cancer management. Another thing, going back to the concept of total pain, is that pain is just not isolated sensory experience. You see that it's going to amygdala, it's going to the cingulate cortex, it's going to the hypothalamus, it's going to the other areas, the amygdala and all the limbic system areas. So there's an emotional component. So as soon as I step on something, I go, ouch, it hurts, right? Or I say something in Punjabi that I don't want to say now. So, but the point here is that there's an emotional component. Next time I see something on the ground, I'll be careful. There's a memory form for it. It is so much important that we just don't focus on the sensory component of pain, but the overall thing that it kind of leads to. Again, same diagram looking at it from a different angle now. Management. Think about this all the way down, there is trauma, the skin of the foot. If you can control the pain in that area, local analgesics, capsaicin, anticonvulsants, NSAIDs, all those things that decrease inflammation in the skin fascial areas, right? You can control pain there. Second part, transmission of pain. Give local anesthetics, opioids, all those things, they work at that point, right? So you can block the nerve, which will transmit the pain up. At the dorsal root ganglion, you can use local anesthetics again, alpha 2 agonists, and all those things. And then in the modulation part, right, you have tricyclic antidepressants, have uh, norepinephrine reuptake inhibitors. And in the brain part, again, the same medications, they work. So it gives us an opportunity to manage pain in different places at different levels to control pain. And this gives us an opportunity not just to control pain, also to manage the side effects. If a person cannot tolerate a certain medication, we can try something else that works at a different level or use them all together to get the best pain control possible. And that's how I kind of about pain management. And that's how we in cancer pain management kind of like deal with pain management. So now the question becomes, why are we treating pain? What is it doing? I mean, it's just pain, just tell the patient it's pain, just deal with it. But the fact is that when we go back to the second diagram that I showed you, there's a area in the brain where there's an emotional response, there is a social response, there is an emotional, I mean, all those things, that area may get impacted. So what happens is untreated pain may do anxiety and depression. I mean, it's going to the areas where mood is modulated. So when that patient is anxious and depressed, they don't sleep. When they don't sleep, when they have impaired sleep, they get confused. And this is something that we see all the time, patients coming in confused because of pain. Then they are not functioning physically. A person who was working, making money, earning, taking care of his family, taking care of his social kind of obligations, all of a sudden, there is no physical functioning. That leads to more issues with anxiety, depression, sleep. So it's almost like something that blows out of proportion. It's a vicious cycle of badness. Then eventually in older patients, what we see is that they start falling. They break something, a femur, something else, injury, a subdural hematoma. And then eventually, I mean, it's a continuous decline that leads to, unfortunately, much worse outcomes. So this is why it's important to control pain in cancer patients. Again, this is something that we all know, but just to kind of recap on things, nociceptive pain that has two components, with two kind of types, basically. One is visceral, one is somatic. Think about this, right? You go to a cricket ground, right? And there's a batsman who hits the ball and comes in and hits you in the face, right? At that point, you get pain, swelling, redness on the muscle face or wherever the ball has hit. That is somatic pain. It is more related to muscle, skeletal issues, right? On the other hand, visceral pain is more so something deep inside. Appendicitis pain is a kind of like a example for it, right? So that's the difference. The other thing is neuropathic pain. We get this very often, not just because of the patient's pre-existing comorbidities, which can include diabetes or other kind of illnesses, but also because of the chemotherapy, the platinum-based treatments and all those things that can cause a lot of neuropathic pain. So that is something that we have to treat as well. And that's a type of pain that is very common in at least European settings. And then, because in most cases, almost I would say 90% of cases in at least my clinical practice, what we see is mixed pain, which is basically you've got pain from visceral sources, somatic sources, neuropathic sources, and then you have the psychological kind of like issues that happen with things. So what we deal with is this mixed, unspecified pain. Tumors pressing on an area around the muscle, it's hurting in the muscle, it's hurting in the viscera, the nerve around it is also hurting. So this is what we, and that's what makes it so important to kind of look at the whole picture and kind of treat pain as a multimodal kind of entity that can be treated with multiple options. So general principles of pain management, again, something that we teach our residents right away is set a goal. When a patient comes to you, set a goal of reduction of pain to tolerable levels. I always tell my patients that, oh, I'm seeing the messages as well. Thank you so much. We'll look at it at the end. General reduction. So think about this, right? Uh, If I give pain medications that make them sleep, I can cause an overdose. They try to like achieve full, complete relief. So what we want to do is try to get them pain relief to a point where they're comfortable. They're able to do things that they want to do, right? It's not that something we can promise that we'll take care of all your pain. It's a cancer. It's doing bad things. It's got a whole kind of like syndrome to it. So we will reduce to a tolerable level. You can play with your kids. You can do basic things that are important to you without much stress. Second thing is start with go up. Very important because of side effect profile. Don't start with because that will overdose the patient, that will cause sex, and the patient will not take that medicine again. Another clinic visits, or I mean, if you're in patient and inpatient settings, validate it, monitor the tightness. So slowly see them regularly and make sure you get to a point where things are at a point where they're comfortable. And communicate. Communicate not just with the patient, the family, the other people taking care of the patient. In my setting, I talk to oncologists, radiation oncologists, surgical oncologists, primary care. I try to talk to everyone to make sure that I understand what the patient is feeling or what the patient has told them. And from the other end, what they can tell me about some of the things that they are doing to control some of the cancer or the pain, everything that comes with it. Whenever I choose a medicine, there are three factors: patient factors, and diseases. First thing is patient. Okay, what kind of basically patient is it? I mean, what kind of like comorbidity patient has? Does he have gastritis failure? Does he have diabetes? Any that can interfere with my medication or my medication prescription. Medication factors, that's the other thing, right? If a patient is already on multiple things from a certain class of medication, you don't want to repeat that. You want to try something different. But disease factors as well. Think about what the underlying disease is. Is it inflammatory pain? Is it neuropathic pain? Is it somatic pain? So think about all those factors. And based on these three factors, what kind of patient it is, what kind of comorbidities they have, what kind of medication am I are what are the benefits or harms from it, and what kind of disease factors are present that are causing the pain. That's what helps me decide what kind of pain medication I use. This is something from 1986, almost 39 years ago, almost 40. Basically, WHO, World Health Organization, made a pain ladder. They said for cancer pain, there has to be steps of management. So step one is mild pain, something like aspirin. I mean, we don't use it for pain anymore. It's a 1986 document, like I said. Acetaminophen, anti-inflammatories, and adjuvant pain medications. If the pain is moderate, which is 5 to 7 out of 10, use pain, hydrocodone, oxycodone, and tramadol. And I do understand some of these pills are very hard to get in certain countries. So moderate pain, we use this. And in severe pain, basically in 8 to 10 out of 10, we use things like stronger opioids like morphine, hydromorphone, methadone, fentanyl, oxycodone, with other things as well. So this is how we think about it. Okay, so pain is 1 to 4, 5 to 7, or 8 to 10 out of 10, and what can we start it as a first level? Before we go to the opioid medications, we always try to manage pain with over-the-counter medications, things that have been tried before the patient has used and may have benefit from. So one of them is acetaminophen, right? Um, It's something that can be used 650 milligrams to about 1,000 milligrams 3 times a day or so. The only thing is that there's concern for hepatotoxicity, especially, I mean, we don't have that issue in Pakistan as much, but at least in the US, we ask about hepatotoxicity factors, other medications that they may be on, alcohol consumption. So we try to keep it around maximum of 3 to 4 grams. We won't try to go above it because we don't want to mess up the liver profile. Second thing is NSAIDs, right? That's something that can be used for mild pain, ibuprofen, naproxen, COX-2 selective inhibitors. The biggest concern is the renal toxicity, issues with hypertension that can happen, the platelet dysfunction, and the gastritis and all those peptic ulcer-based things that can happen. So if a patient already has those things, we usually don't use these medications. The big one, opioids. So basic pharmacology. They are agonist at the kappa receptors. They are conjugated in the liver and excreted by the kidneys. So there is a liver component and there's a kidney component. So you have to be careful that if someone has dehydration, if a patient has renal failure or hepatic failure, either you decrease the dosage of the opioid because it's conjugated in the liver and excreted to the kidneys, or you extend the dosing interval. Instead of every 4 hours, maybe use every 8 hours. Instead of every 8 hours, maybe use every 12 hours. So that is the important aspect of pharmacology here. And then you also have to be careful about the central and peripheral effects, overdose, I mean, constipation, nausea, all those things. They are really important. This is a diagram that I copied from another presentation, but it kind of tells us about the IV versus oral route of administration, how they differ in patients who are getting opioids. So plasma concentration, let's say if you give oral, it basically slowly goes up and kind of plateaus and then comes down over 5 to 6 hours. So that's how it works. On the other hand, if you give IV opioid, it works right away, but in the red column, in the red graph, it works great, but it leaves the system fast. So you have to dose it more frequently. So if I were to give an oral opioid, oxycodone, I would probably give it about every 6 hours. If I'm giving an IV, which will work right away and give analgesia right away, I would probably use it every 3 to 4 hours because, as you can see, it comes out of the system really quickly. Side effects, big ones, constipation. It's something that the patient never becomes tolerant to. You always have to give laxatives, stool softener, stimulant to control the constipation. Otherwise, you've got another issue at hand. Nausea and vomiting. Thankfully, this is something that the patients get tolerant to in the first week or the use of opioid pain medications. You can use anti-nausea medications, D2 blockers, 5-HT3 medications, so that can help with this. Sedation and confusion, that's a big one. Patients can get sedated, confused. So we often tell patients don't drive, don't operate heavy machinery. That this is an important part of these medications. Itching is something that can happen. And usually when the patients get sedated and confused, the next step is that we start seeing respiratory depression. So we don't want them to get overdosed. So that is kind of important. Another part, let's say you start an opioid, right? How do you ramp it up? So let's say I'm starting an opioid. The patient says, Doc, I still have mild pain. I still have pain that is bothering me. So at that point, I will increase the opioid dose about 25% and see how they do. Let's say after giving a patient a pain medication, after a week, they come in and they tell me, Doctor, I still have moderate pain, which is basically 4 to 6 out of 10 pain. I mean, it's a different scale in different places. And the patient says, I'm in moderate pain. So what do? You increase it about 25 to 50% the dose, whatever they were on. And let's say if the same patient comes in and says, Doc, you gave me this medication. It was really good, but I'm still in a lot of pain. What can we do? It's severe pain, right? So in that case, we will increase the dose by 50 to 100% and then follow them again. Those are kind of the ramping models that we use. Other things, adjuvants, in addition to opioids and over-the-counter medications that we discussed, what else can we use for cancer pain? We can use topical pain medications. Think about that first diagram. Local anesthetics, things that we can put on the skin locally, capsaicin creams, all things. Bone pain responds really well to steroids. Uh, and steroids are also helpful because if someone has cancer, they are not eating, they have low energy. So steroids can add more benefits there. For certain inflammatory pain, bone pain, steroids can be really helpful if you use them for those purposes. Antidepressants, right? Things like SNRIs, things like TCAs, tricyclic antidepressants, right? Amitriptyline and all those things. They can be really helpful with not just, but also the neuropathic component of pain. And this is something that we often use in conjunction with everything else. Antiarrhythmics, that can be something that can be really helpful, non-pharmacological things. Another thing that we use very often is gabapentinoids, things like gabapentin, pregabalin, all those things for neuropathic pain. So the idea is, again, going back to the diagram, if I have many places where I can kind of control pain, how many places do I want to hit by multiple drugs, which is called polymodal analgesia? How many places do I want to hit the pain and basically reduce it? And that's usually the approach in cancer pain, which is mixed pain. Now, the second thing that I get to do is interventional cancer pain management. So we do nerve blocks, we can do intrathecal pumps, and all those things. And the idea is that sometimes patient's pain cannot be controlled with oral medications or there are too many side effects. So these nerve blocks and all those things can block that area so the patient does not have pain in the brain. So NCCN, which is basically the biggest organization for cancer-based kind of like guidelines in the US, it publishes annual guidelines, and basically it's one of the newer guidelines, but it talks about interventional strategies. When do we start doing procedures, right? So there are two basic indications. Number one, pain is likely to be relieved by nerve block. Number two, failure to achieve adequate analgesia or the presence of intolerable adverse effects due to the medication that you're giving. So either patient is like, doc, this medication is not controlling my pain. I'm still in a lot of pain. I'm getting too many side effects, right? Or whatever we're doing, it's causing too many kind of like tolerability issues. So in that case, we can do nerve blocks. What can be done? There's a whole list. We can do intrathecal pumps, we can do infusions of local anesthetics, kyphoplasties, vertebroplasties, nerve blocks, intercostal, celiac, ganglion impar. So the saying is in interventional pain, where there's a nerve, there's a block, except for vagus nerve, phrenic nerve, and the cardiac. You can pretty much block that nerve so that there is at least analgesia for a couple of months. So these are the options that we use. So first question is, what's the role? So number one, this is never an isolated thing that you can do. This is to be used in conjunction with medical management, and this is on top of that. So if you do a nerve block and you decide that I'm going to stop all medicine and patient is not going to need any pain medicine, that would be not correct. This is something that is done in addition to medical management. And the best part is something that I love about this is that there's more rapid control of symptoms, right? When a patient takes a pill, it takes them at least 40 minutes to make it work. It has to go to the mouth, into the pharynx, into the esophagus, go into the stomach, get dissolved, go into the small intestine, get absorbed all the way down in the ileum, and then basically it reaches its target area. The point is that and basically this whole process from all the way to the ileum takes about 40 to 45 minutes. And if the patient has gastroparesis or something else, that will take even longer. So the question for me is how can I get rapid analgesia? So as soon as I put the needle in and put the local anesthetic, the patient gets immediate analgesia. So there's rapid control of symptoms. The other thing is that since it complements medical management, it may reduce opioid requirements, which means lesser constipation, lesser overdose issues, lesser sleepiness, itching, nausea, all those things. And then lesser issues with abuse, something that we all are concerned about, opioid abuse specifically. So that's the good part about interventional cancer pain management. So I will talk about 4 or 5 things that we do in interventional pain. So one of them is intrathecal pump. Basically, this is The pump that we have, it's about the size of my palm. It comes in different sizes, 20 ml or 40 ml. It's basically a reservoir. It's kind of like an area where through the central area, you can see in the middle of this device, you can put in the medicine, you can take out the medicine, and this little wire that is going from the upper right corner, this will go into the spinal area, in the vertebral area, in the epidural space, or usually in the spinal area, subarachnoid area, and it will continue to release a little bit of medicine that will provide analgesia. So why do we put this pump? So when patient has refractory pain or their side effects, pain more than 5 out of 10, so that's when we can do it. How? Like I said, this is delivery of drug directly to the spinal cord, and you're bypassing the GI tract, liver. You put it in the spinal canal, and it goes to the brain, provides analgesia. So that's the difference. When you give an oral medication, it goes all red, all over on the right side. But if you give through the intrathecal route, it just stays in the spinal canal, causes lesser side effects, and need almost a very small amount of pain medication compared to some of the other uh, or IV medications. Usually it takes me, or if surgeon is doing it, about 2 to maybe 3 hours to put it in. We do it under general anesthesia. So what we do is that we make a vertical incision in the back through the spinal needle. We'll go into the spinal canal. We'll basically this catheter in. The device itself, it goes into the anterior abdominal wall. Is there in the anterior abdominal wall inside the skin, above the muscle, and basically in the facial area, it's present and it's slowly releasing the medication. It's got a little pump inside, it's got a little motor inside, and it continues to release a small amount of medication in the spinal cord. And this catheter that you see is basically tunneled, basically from the anterior abdominal wall into the spine. Then we can program it, right? So I can tell this device that, listen, release 2 milligrams an hour, release 4 milligrams an hour. And then the patient gets this device. It's called a PTM. I mean, it's one of those almost like a PCA, which is like wireless PCA. So the patient can put it near their device inside their body, and they can press it so they can get a PRN or an as needed dose as well. So that is the beauty of it. It's a walking, deprogrammable kind of that continues to release a continuous stream. And if the patient wants to give them an extra shot, they can also give themselves an extra shot. You can always uh, take out the old medicine, put in the new medicine, center. That's the port, and you can take out the medication to pump or to the pump. So what can we put in this pump, right? It's a basic motorized. You can put hydro for it, and local anesthetics like bupivacaine, mix that in. We can put clonidine, ziconotide, which is a saline toxin, which helps management. We can use baclofen. So basically, medication, you can make a big mixture, put it in there, and that work for a patient. One, because sepsis, infection over the back, neutropenia, stenosis, all those things that where your device in. If there's something wrong with that, I mean, we try not to put this intrathecal pump in there. That can happen when you put this in any surgical procedure, infection, failure, or pumps fluid that builds up around the pump. Catheter is another one that can happen in the skin, and that's something that you have to treat or kind of prevent. So that is how we use the pump. These are the side effects. So I want to go into the more visceral part of pain management now. So the nerve blocks that we do, there are three basic ganglions in the body. So if you look at the top part, something that comes from the lower esophagus in the red block in the picture, the this is the epigastric area, mid-abdominal area. This area is kind of modulated by the celiac plexus. That's all I want you to know. It's modulated by the plexus. Any pain in this area in the red block up top will be modulated by that. It's a sympathetic. In the middle one, which is the yellow block, that is the transcolon all the way down to the pelvic organs. That area is covered by superior hypogastric plexus. And all the way down into the orificial area in the perineum, at that is, it's the green block, and that is ganglion impar. So if a patient has tumor in the topmost part, I will do a celiac. If the patient has pain in the central part, I will do a hypogastric block. If the pain is all the way down in the orificial area, the perineum area, I would do a I would do a ganglion impar block. And that's how we're going to go about it. Celiac plexus block, the top one, right? The red top block. Celiac plexus anatomy, this is a picture from Gray's Anatomy. Plexus lies anterior to the lower half of the T12 vertebra and the entire L1 vertebra. So basically, if you look at the spine, right in front of E12 and L1 is this thing present. Front aorta and behind the pancreas. So this picture is kind of showing where it exactly is. And basically, it carries pain from all the abdominal viscera, except from the left colon and pelvic and viscera and rectum and bladder area, which are the other ganglions that I showed you earlier. How do we do it? We basically initially, under fluoroscopy or endoscopic ultrasound or CT kind of thing, we will, under local anesthesia, basically target this area. Patient lies on their belly. Under local anesthesia, we put the needle in and we reach ganglion and we put local anesthetic. Once you put the local anesthetic there, the patient is still not usually sedated. We asked the patient, okay, your pain when you came in was 8 out of 10. I just put the local anesthetic in. What's your pain level? The patient says, well, it's working really well. All of a sudden, my pain has gone to like a 0 or 1. At that point, we will leave the needles in, and at that point, put the alcohol or phenol or something in there, which will completely destroy or ablate the nerves in that area. So once the nerves are destroyed, that means long-term analgesia, and that's what we do. One step procedure takes about 10 to 15 minutes. If you're doing two-step procedure in which you're doing alcohol infusion, it takes about 30 minutes or so. This is what it looks like. So you see the yellow thing, that is the celiac plexus, in front of the T12 L1 vertebra, in front of the aorta, and behind the vena cava. Put two patient is lying on their belly. You put one needle from one side, another needle from another side, reach the almost the side of aorta, local anesthetic first, block the area, and then you burn that area or blade or neuralize that area, that plexus, with alcohol, phenol, or any other toxic thing that can cause nerve degeneration. This is what it looks like when I'm doing it under X-ray or fluoroscopy. That was the AP view, and this is the lateral view. You just behind the aorta, and you're putting the dye and then burning that plexus. Second block, which is the hypogastric block. Basically, hypogastric plexus is done the same way. The only difference is that compared to celiac plexus, which was at T1, this hypogastric plexus is at L5 and S1, right? So you are much lower. And so that's where you're accessing the plexus. And what it does is that it goes to the cervix, uterus, bladder areas, prostate, and ovaries and all those areas, and that's what it covers. Transverse colon all the way down to the orifices. Done the same way, two-step procedure to 15 minutes for one step, takes about 30 minutes for two steps. Nerve block, whatever you do, section nerve damage can happen. This is what it looks like on AP view. You are at L5, L1, L5, S1 area, right above the pelvic brim. This is what it looks like laterally. And basically you block all the areas of the lower abdomen and gynecological areas where tumor causes a lot of pain. Third one, all the way down, is the ganglion impar. Remember the third area all the way near the orifices on that big diagram I showed you? In that area, ganglion impar basically blocks the nerves. So those sympathetic chains, which made celiac plexus at T12L1, and then hypogastric plexus at L5S1, right in front of it, in front of the sacrococcygeal area, all the way at the bottom of the tailbone. They converge. On the right side, you can see the two nerve plexus coming in and converging. When they converge, make this terminal thing, a nerve structure called ganglion implant. It's right behind the rectum and in front of the sacrococcygeal ligament. It innervates the perineum, which is basically distal anus, distal third of vagina, or urethra. So any tumors there, you will block them with this. Same way, two-step kind of a thing. You do it 10 to 15 minutes to do a one-step. Two-step, it takes about 30 minutes. And there are good case reports showing benefit from it. Bad things that can happen, rectal perforation, you're very close to it. So we always use guidance for this, bleeding, infection, and all those things that can happen. This is what it looks like when you're doing it on a lateral view. Now, going to a different area, chest wall, intercostal nerves. We all know they'll run intercostal groove in the intercostal bundle. So they go from the back to the front and they go back. So basically, target this under fluoroscopy and ultrasound and burn the nerves. So this is what it looks like. Why are we doing this? If there are rib metastasis, you do it for that. Compressing tumors on rib, you do that. Chronic pain after mastectomy, yes. And in patients when they have neuropathic pain of the chest wall due to shingles or something else, that's something you can do this as well. Again, local anesthetic first, two-step procedure. The biggest con for this is that every time you do one, there's a 1.4% chance that you cause pneumothorax. That's a big one. So we do it under dual kind of imaging with ultrasound as well. So on the left side, you can see what it looks like on the fluoroscopy X-ray kind of a thing. And on the right side, you can see the ultrasound picture under which we do this. We want to basically stay below the rib, but above the pleura, and that is the difficult part, and that's what you can see here. Our needle is going down from the left side where the arrows are pointed. Vertebroplasty and kyphoplasty. So, why do we do this? We do this when there are three things present. It has to be painful, compression fracture with no neurological signs. And if you do this, it can help with a lot of pain. So we do it under general anesthesia. It takes about an hour to do. The thing that we do is we put cement in the broken vertebra, expand it a little bit. So things that can go bad are cement leak, infection, and all those things. So vertebroplasty and kyphoplasty are two entirely different things. They're done the same way, but they have different indications and different kind of like procedures to them. In vertebroplasty, you can see in this diagram, starting from the left, what you're doing is putting cement in the vertebral body. And you're trying to stabilize the vertebra and provide pain relief. So what you do is that you put trocars and all those things inside the bone and you put cement. It's done, right? Simple thing, already broken vertebra. You put cement in, it stabilizes it. But you're not restoring the vertebral height. So the compressed area is still compressed. On the other hand, this is what it looks like. On the other hand, in kyphoplasty, what you're doing is you're restoring the vertebral height. So on the left side in this diagram, you can see you put a cannula in the same way, but you have a cavity that you create by basically inflating a balloon, putting pressure in the bone, and expanding. So you can see in the middle vertebra there that we have expanded a balloon in there. We deflate the balloon, take it out, and once the cavity is created, put cement. So that is the difference. The point here is that you are restoring the vertebral height. So the muscles are in synchrony. They are not like tense or there is a vertebral height that is maintained. So that provides often better analgesia. So that was my presentation. We do both interventional pain and cancer pain through medications. And my hope was that you would get an understanding as to how to manage pain, what are our routes, what are our options, and what are some of the benefits and harms of these therapies. So I think we are options now.
Well, thank you, Dr. Habib. This was a fantastic talk. I personally learned a lot of things from this talk. I'm sure we have more than 50 live people participant at this time, so I'm sure they also learned a lot. We also record this and host on an Apna Academy, where this can be, at this point, it's freely accessible as anyone who can make a account and listen to these lectures. In the near future, there is a talk we may charge a little bit nominal fee, and there are some reasons behind it because anything free, no one values. That's one challenge as well. And so people sign up, but they don't complete the course. I think someone asked the question, are we giving a certificate for these courses? To my knowledge, not at this point, but this is something, a good question for the Apna Academy. So if someone is accessing these courses on the Apna Academy, they should message an email to the Apna Academy leadership. And it should be easy. And if you did the course, we should be able to give you a certificate, but I'm not the one who take the responsibility. There's a question here from Dr. Rafia Tour, and I think it's the challenges of these drugs availability of fentanyl patches is an issue. Even as an oncologist, I cannot advise my outpatient patients. This is somebody who's an oncologist practicing in Islamabad. So I'm sure, Dr. Habib, a lot of people reach out to you, probably from colleagues from Pakistan or friends and family who have questions and concerns. So do you want to make any comment about that? Are you on mute by any chance?
Yes, sorry, I did myself.
Okay.
Thank you. So, Dr. Toor, thank you so much for this question. It's a very real question. I'm from Islamabad. I've had family members who've had cancer in Islamabad, and we ran through the same issue. Fentanyl patches are very hard to get. The question is, can we do to kind of like counter fentanyl patches that the ones that I have kind of come across for cancer pain management in Pakistan? I mean, obviously, there are two things. First of all, they're hard to find. They don't stick as well. So easier they're supposed to. Number three, once you start someone on a fentanyl patch, and then you cannot get it, that becomes a bigger issue because then you have nothing to control it with. You had 10 patches and now there's no supply. And the delivery from that matrix through which the drug is kind of concentrated in there, it's very hard to like I mean have a precise dosing due to quality issues. So what I do, number one, is instead of fentanyl patches, I would think of a long-acting morphine. So in most of the cases, patients are able to take oral pain medications, right? So based on starting on a low dose oxycodone or morphine, I see how much they're using. And once I know how much they're using, I will change them to an oral long-acting morphine. Instead of a 72-hour patch, you are giving twice a day of the morphine long acting. It stays in their belly and it provides analgesia almost the same way with a slow release. It provides a better control as well because let's say if a patient were to get like slightly sedated or overdosed, you just don't give the next dose. In the fentanyl patch, you are kind of limited by the fact that all you can do is basically rip off that patch. Still takes 8 hours to basically kind of get out of the system. So I have come to this, and there are two more factors which I don't like about fentanyl patch. Number one, body heat. If a patient has fever, which cancer patients usually do, will increase the for every degree centigrade rise in temperature of the body, the patient's absorption will increase by 10%. So they are extremely sensitive to heat. If a patient puts it on the body, sits on it, that makes it hot and that increases the absorption. So the patch does not last. So that's another thing. The third is a lot of people, due to the patch, the glue patch that attaches to it, get skin and allergy reactions. Men have a bigger issue. They have hairy skin. It doesn't stick well. People have to do wuzu. People have to shower. You don't shower with it. So in my practice over time, when I used to be a person for fentanyl patches, I've almost changed myself to either long-acting morphine, long-acting codone, long-acting morphone, long-acting hydrocodone, whatever is available, gives us a better option to create. gives us better control, gives us more options to change things. The only place when this thing doesn't work and a fentanyl patch becomes a really big issue is if a patient starts getting intestinal obstruction because of their GI tumor, which initially I believe was pretty high, but it's not as much. Patients on most days can absorb a medication from their small intestine. They can. Other factor here is that morphine and oxycodone tablets are easier to get. They have lesser fentanyl, unfortunately, because of multiple other factors, has got a lot of stigma to it as well. So my practice recommendation to most of my colleagues in Pakistan, Islamabad, is try to get long-acting morphines and long-acting oxycodones. They will provide you better control, better analgesia. The only thing is that if someone has had a neck cancer and you've put a in them, you cannot crush that tablet, and that's the only place the value of a fentanyl patch. But in most cases, you can counter that. But amazing question, great question. Supply is an issue. We cannot control that. It's out of our control. We can control what we can give patients in addition to that as a separate option, and that's how it works.
Well, thank you. I'm feeling the questions. This question is a little bit vague. How many chances of infection for the intrathecal injection? So I don't know if the question is about the pump or just the intrathecal injection. So go ahead, please.
So, this is a decent question. I'll tell you why. Because you are in a way asking me two things. What you're asking me, number one, is can there be an intrathecal injection that can be done? The answer is yes. The same way you do an epidural, you go a little deeper, you're in the subarachnoid space, and you drop the anesthetic or the pain medication. That's an intrathecal injection, right? Bad epidural injection, it's an intrathecal injection. You've gone too deep and you are pulling out CSF now. So it can be done. You take strict cautions in cleaning that area and make sure that you provide sterility. Your technique is very sterile. The risk of infection is very low. That's the key. And even I keep the patients in my clinic for another 30 minutes to an hour, just to ensure that CSF is not leaking, all those things. But bad things can happen. There was a study that was done in 1980s or 90s. I mean, I remember it from old data. I mean, they had about 3% infection rate to that. The second part to your question is intrathecal pumps, do they get infected? So initially when intrathecal pumps came in 2005, 2006, around that time, infection rate was about 5 to 7%. That was very high. Sterile techniques and improved surgical techniques with better pumps, better materials made for it. It has gone nationally in the US to about 2.5%. So that means that 97.5% times you will not have an issue. Problem occurs when you do. Because once you do, you've got a dirty pocket where you've put this foreign body. You have to take it out. That becomes a bigger issue in a patient who already has cancer. So we have done, when we put these in, we are extremely careful. OR, general anesthesia, everything. And we make sure that we do it fast so that the risk of infection is less. So we have brought it down in our hospital settings to about 1 to 1.5% or even lesser now. So we are very happy with our numbers. So the answer is that your technique, your surgical approach, all those things matter. And a good surgeon who's doing them regularly, good quality pump, it should be almost negligible. But that's something of a fear. That's a surgeon's worst infection, worst kind of worry. I put something in, the patient was already given anesthesia once. Now I have to put them in anesthesia again, take this thing out, and they don't have analgesia now. That's the worst outcome that can happen. So thankfully, it has never happened to me, and I continue to hope that it doesn't happen, but real fear.
All right. There is some student is saying that I'm an undergrad student and they want to see if there's some reading material that can be provided. Well, students, I want to let you guys know if you type in APNA Academy, APPNA Academy, this lecture will be edited and will be soon hosted, shared via WhatsApp, and as well as uploaded on the APNA Academy website. And the slides will be visible. So you can, at your own convenience and pace, you can pause, look at the reading material. I don't know if Dr. Habib has any particular resource to share, but that's something can be done as well.
No, great. Thank you so much. So the answer is, I'm going to put this in the chat right here once I figure out how to do this. Here you go. That I wrote with a very good team. One of our common friends, Dr. Anwar, Dr. Raza, wrote this with us, and it's open access. And it is intentional pain management in cancer setting. And it talks about all these approaches. It talks about how these are done, what the long-term outcomes are, and some of the questions that you asked me here, they're answered there. So it's open access. Go to this link. There's a PDF that you can download. There's data. There are examples, and there are the adverse effects, indications. Everything is there. So feel free to download. It's free access. If this helps, that's great. And like Dr. Anwar said, I mean, there is a great opportunity for everyone, including us, in practice, to learn about what our colleagues are doing in different parts of the country, different parts of the world. So please use this Apna resource that we have. I think it's a great resource. And like Dr. Anwar said before, which was a great point, that you have to put a little money on it to make it valuable.
Right.
But please use this resource.
Yeah. No, well, currently it is free, but we're realizing more people are signing up, but they don't value it. And they're a fraction of the people who sign up, they complete it. So it's kind of a psychological thing. A few days you're not paying anything, you're not valuing it. So that's one reason. The other reason is, all these resources cost money, so we have to have some funding stream to support it. The other advice for our students is, instead of I should be reading an anonymous attendee, please, be brave, put your name there. I'm not saying that you should put your picture there as well. I don't see anything bad about it, but at least put your name. You're a student, be brave and put your name there. There was another question. What about Cymbalta and amitriptyline as compared with GABAs?
Amazing question. I think this is a question that I answer to patients and my colleagues at university, if not more. So what you're asking me specifically is, let's break this question down. Let's do it this way. We've got about five minutes or so. Their mechanism of action is completely different. Amitriptyline and Cymbalta. One is a serotonin norepinephrine reuptake inhibitor. The other one is norepinephrine reuptake inhibitor. I mean, basically, it's a tricyclic antidepressant. So basically, it's kind of modulating different areas. They are both used for neuropathic pain. And the other thing, the gabapentin, it works on the calcium channels, and basically it impacts the chloride kind of like activity as well. So let's think about this, right? Uh, Efficacy. In the sense of efficacy, we all know NNT, which is number needed to treat. So for neuropathic pain in patients, because that's primarily what we're treating with it, right? In neuropathic pain settings, the number needed to treat for amitriptyline is about 2.2 or something, somewhere around that range. The number for pregabalin is around pregabalin or gabapentinoids is about 3.5. So you need to treat two patients almost with amitriptyline to get that response of analgesia, and about three patients with pregabalin or gabapentin. The same number, about 3 to 4, somewhere around that range. NNT is relatively higher. Point is, amitriptyline is antidepressants are more efficacious than pregabalin, gabapentinoids, even Cymbalta, which is basically duloxetine. The issue is amitriptyline has a lot of side effects. It's got a lot of anticholinergic side effects. It's got a lot of cardiac side effects. And it is something that in older patients can cause orthostatic hypotension and they can fall. In older men, it can cause BPH to get worse, so they can have blockage of their urine. To monitor QTC interval on the EKG regularly on this. So it becomes, as a clinician, a bigger pain for you to manage it safely. Thing is that if you're putting patient on a trial, imitation's QTC prolonging effects will prevent it to be on a trial. So in cancer cells, it becomes a more difficult thing. So what we like to do is use something like gabapentinoids, which have side effects which are more so related to sedation and a little bit of fatigue, but they are more manageable. And there's less monitoring and titration required. They can go on trials, all those things that are really important for them. So that is the difference. So whenever I choose gabapentin versus duloxetine versus amitriptyline, I ask the patient a couple of questions. Number one, are you sleeping? Because if they're not sleeping, gabapentinoids can help and the amitriptyline can help. They're both sedating, right? If it's an older man, I probably won't use amitriptyline. Monitoring and patient compliance, I won't use it. I would use gabapentinoids. Now, if it's a younger patient who wants to do things, sleeping okay, I would use duloxetine in the morning because it has got a norepinephrine reuptake inhibition, so it gives them a little more energy, so they can continue to work and not get sedated. So it depends on symptoms they have. The other thing is that you give an anxious patient, they are going to have a nervous breakdown. So you cannot give them that. But on the other hand, Cymbalta will be good. So again, going back to patient factors, medication factors, disease factors. Think about those when you start this. So more efficacious, amitriptyline, more side effects, amitriptyline, better tolerated, easy to manage, duloxetine. Figure out what is the best under those circumstances.
Well, thank you. And we have few more minutes, but I want to talk about some words of caution. I do not want trainees or juniors to watch this lecture and then start doing this procedure on their patients. So the question is there a well-recognized center which is now providing training in the region? And then I want you to please warn these guys who are young guys, maybe ambitious, and they say, well, we saw the lecture, we are now trained, and so let's do it. Patient is suffering and I want to help them, but I know that that will lead to more harm. So I want you to please give us some words of caution as well.
Dr. Edward, thank you so much. And this is something that we tell our trainees as well. Listen, we all want to help our patients. We all want to support them. We all see the suck and we all want to take that away. But we have to be safe, not just for the patient, but ourselves. A bad procedure obviously means bad outcomes for the patient, but for us as well, right? So for in the US, interventional pain training takes, you have to have a baseline in anesthesia, physical medicine, and rehab to understand the basics. And then of actual clinical surgical training before you can do these things. These are procedures that are fraught with issues. Anytime you put a bad injection in someone, you can paralyze them, you can cause a bad infection. All these sympathetic three blocks that I told you about, you can enter aorta, and that's something that you don't want to do. You have to pre-screen the patient. You have to know what you're doing. You need to have, it's almost like you have to have at least 10 to 15 procedures under your belt before you even do one solo. So please train yourself before you do any of these things. Second part, there are places where interventional pain training is being provided after anesthesia. In Pakistan, I know Arakan has one. I don't know if Shifa has one, but they have some decent interventional pain specialists there. I know Shaukat Khanam has some sort of training in that as well. So again, I think CPSP website, all those things will provide you better understanding of where these centers are. A better center where you get to do more procedures will mean that you will get more proficient and your complication rates will be low. And very clearly, I mean, obviously, this is not legal advice, but I would not want anyone to do these procedures without having certification, training, and understanding. Without that, it's a disaster for anyone involved.
Thank you. And that's exactly wanted them to hear because I know the mentality of a young guy who's ambitious, want to do it and saw it and want to help them. So this is great. Thank you. And I think at some point so I just heard 3 centers and we don't know where their capacities are. Maybe they are great, but if they are not and they want to reach out, then I think that's where there are a lot of Pakistani physicians from the region who are trained, and the CPSP and the centers need to have some sort of a partnership and a formal invite. And a faculty here is always willing to give back and go back and especially train the people who want to help and serve with dignity and with excellence. So thank you. And once again, thank you for this was great. Thank you for your presence and giving us your precious time and expertise. And we'll look forward to have you come back at some point and build on this, what we started. Thank you.
To Dr. Anwar, thank you everyone for attending.
Goodbye.